Our first speaker is Christopher Edwards. It's not his first trip to Northern Ireland. I recall not too long ago when he came to speak to rheumatologists about lupus. Christopher is Professor of Rheumatology at the University of Southampton. He's a consultant in the University Hospital there and also works at the London Lupus Centre. He also has a lifelong interest in lupus research, and we're looking forward very much, Christopher, to hearing what you've got to say about new treatments for lupus.
Now, for me as a rheumatologist, I got interested in doing rheumatology as a speciality because of lupus. When I was a medical student, I did an extra bit of science in my training called an intercalated BSc, and in that time did some research on lupus and became interested from that time on. And then I've been lucky, and I'll touch on this a little bit, to work in different environments, to work in London, a very multicultural environment, to work in Singapore, to look at the differences in the way lupus presents. And when we think about treatments, hopefully I'm going to touch on some ideas about how we might choose treatments to make sure we give the best treatment to every individual we see. There's a tendency, inevitably, when we look at trials of therapies for patients, when we try and work out how to treat people, that we mass everyone together and we say, those lupus patients on that drug versus that drug. And of course, everyone has a very unique brand of the disease. And I think Professor Bruce later is going to talk about how some of the cleverness about how we approach medical treatment in the future is about stratifying, about looking at an individual or small groups of patient level to decide how best to treat people, and that's something I'm going to touch on as I go through. So what about challenges? Well, this is a very generic starting slide, just to think about what we might like to do if we treat people in the best possible way when we see them in clinic. We'd like to see people early. We hear from patients all the time the delay in diagnosis that patients often have. Sometimes that's difficult to explain why it's taken so long. Sometimes it's just that things are complicated and haven't presented in an obvious way. We want to be able to guess, that's what the prognosis bit is, we want to guess how someone will do. And when you first meet someone, that can be very difficult. Sometimes it takes a little bit of time for it to be clear how someone's lupus will develop, and then to try and guess, how bad will this be? How aggressively do I need to treat? What new treatments do I need over time? And then, of course, and this is something I'm going to mention more about, we need effective and new therapies. But we mustn't forget that we have lots of therapies that for many people work very well already. And so we need the best ways of using the treatments we already have to maximise their efficacy, how well they work, and to reduce the likelihood of side effects. And do that as well as we can, not just throw out all the old drugs and say everything must be new. And then finally, and this is something that a number of us have been involved in through organisations like the BILAG group, is having a really good scoring system. You can imagine, if you have an individual with lupus, I want to know how well they're doing. And I want to hear them tell me I'm doing well or I'm doing badly, and I might have my own view, but I want to be able to give it a score, give it a number as well, so I can do it in a more scientific way over time. And that's something that's being developed. Now, I think you have to also start with saying treatment in lupus has been a bit of frustration as well. And that's for some reasons that I'll touch on. And maybe it's because of the complexity of the disease. It means that grouping all the people together and saying this is lupus, as opposed to saying this is kidney lupus and this is skin lupus and this is joint lupus, or this is Mrs. Brown's lupus. The difficulty with that is perhaps that in the trials we do, in the trials we try and use to work out if a treatment will work, and ultimately to convince the people who pay for drugs that it's worth them paying for those drugs for us to give to our patients, that makes those trials very complex because of the complexity of the disease. And that may be one of the reasons we feel frustration, because lots of the trials we've been involved in over the last decade of drugs that we really think work in some of the patients we see, when you look at the numbers, don't always seem to come out as being effective in the trials we do. And I'll come back to bits of hope in a moment. So what about the challenges for trials? Now, there are lots of things that make trials of lupus difficult. I've mentioned the complexity of the disease and how everybody can be very different. It's complex deciding how you score people as well. If someone has a bad joint, or a low blood count, or a bad kidney problem, those are very different things, and how you sort of weigh up how important that is in different people is also important. One of the other things that happens as well is that when studies are done, people will have variable amounts of other medicines. So you can imagine if I have a study and we have patients that have very high levels of steroids, of prednisolone in the study, that might interfere with how well the new drug looks to be working as well. So there are various things people are working on to try and overcome those challenges for the trials that we're doing. So what about key questions for therapy? What am I thinking about? If I was designing my ideal drug and you could just pick it off the shelf and go, that's the one I want to make decisions about how aggressive that drug is. Some people need very mild treatment. Some people need very aggressive treatment because they have life-threatening, rarely disease. And you want to be able to have a drug or drugs that will address those different degrees of severity. I want to think about how much steroid I use and try to limit steroid. When I was training, I spent some time at St Thomas's, and there, one of the things that Graham Hughes was really pushed very hard, and I think personally is one of his biggest contributions, is less steroid, less steroid, less steroid. Not to be frightened of it, it's life-saving in many people, but to just be cautious and thoughtful about the doses we use. Not frightened of it, but cautious and thoughtful. Nice to treat people early, so we'd like to be able to do that. We'd like to be able to have an idea about when to treat people, and then there's a difference between lupus is often, many of you might have had this experience, it's a relapsing and remitting disease. What that means is that there's a flare and it's really bad, and then you might control it and it's okay for a bit, and then it does the same again. That's not the same as something that's just bad at a certain level all of the time. So you have this challenge of inducing remission at the beginning, and then maybe using less treatment over time to control the disease. So there are those complexities as well. So different things to think about. Now here are the sorts of conventional treatments that we might use, the things that we might have been using for years and years already. And I think it's really important whenever you talk about anything new, not to throw out all of the old stuff. We're all excited by new things, new research, new opportunities, new things to do, beguiled by the new ideas. But many of the older drugs we use are very effective if used correctly and well, and if we're sensible about it. Steroids I've already mentioned, I'll mention a bit more in the future. Hydroxychloroquine as an anti-malarial drug for mild disease is often very effective. We like to continue that in many patients. And then there are a number of different drugs which have these unusual names which might or might not be familiar to you, but immunosuppressives, things that damp down the immune system, or they're also sometimes called disease-modifying anti-rheumatic drugs. Some of you will know these drugs, like azathioprine and mycophenolate mofetil, perhaps as two of the more common, and then some of the others that are used in lupus, but also in other diseases like rheumatoid arthritis. And then traditionally, we also used a cytotoxic drug, but at lower doses than in some other diseases, called cyclophosphamide for the worst disease, the kidney bad, the lung bad, the brain bad disease, the sorts of situations where we really need to control disease very aggressively. Now, I thought I'd illustrate some of this by mentioning to you a patient, and I'll show you some of the patient slides in a moment, so I hope you don't mind seeing some clinical slides. There are scans of the brain and things like that. And I asked the patient, whose name is Becky, if she'd mind, so she knows I'm going to present her story to you. But it just illustrates some of the thoughts we have when we're treating people. So this is a scan of Becky's brain, and this is now from several years ago. I was looking to see the date on it, but it must be, it's probably almost 15 years ago. It's that sort of time when the scan was first done. And I met Becky, first of all, when she was 13 years old, and she was just going through puberty. She had a history of having had a blood disorder called hemolytic anemia, where your immune system smashes up your red blood cells and you become anemic. So she'd had that for a few years, but was generally well. And then she started to get some rashes and some joint aches and pains. And then very, very quickly, I saw her, and within a few weeks, she developed terrible bad headaches and ended up on the intensive care unit. And the reason she was on the intensive care unit, on the neurological intensive care unit in Southampton, was because she had some blood clots in blood vessels within her brain, because she had a sticky blood syndrome called antiphospholipid syndrome and very active lupus at the same time. And that was, these clots were shown in a couple of different ways. This is another way of showing it. And the arrows are showing the areas where there should be blood, which would show as white. That's the dye that's been injected in to show this and isn't getting there. And I'll mention Becky's story a little bit more towards the end as well, but it sort of illustrates, here's a young woman, I'm thinking potentially I have to treat her for many years. I want to maximise my ability to control her disease in what is a very dangerous situation for her. And of course, most people with lupus don't get as bad as this, but as an illustration. And I'm also then thinking how I limit side effects from drugs and the disease over years and time, and I'm thinking inflammation and blood clots simultaneously and how you control this. Now, I apologise for this. This is a dreadful slide to show to you, isn't it? And I was wondering when I was thinking about talking about new treatments, how you illustrate the complexity of all the different things that we're doing. So first of all, just look at the two circles. The circles illustrate white blood cells in our bodies. We're all here today because our ancestors were the ones that had the most aggressive immune systems. Our immune systems being those bits of our body that fight infection and germs. So our ancestors survived Black Death, bubonic plague, TB, flu pandemics, all these terrible infections. And it means all of us have very aggressive, sharp-set immune systems just on the edge of becoming confused. And what a lot of the new drug development for lupus has looked at, and for other inflammatory diseases, in saying, okay, if we look at the white blood cells that are important, the B cell you can see there, the T cell, these are white blood cells, and we look at all of the different little proteins that are stuck on them, and all of the little messages that they require to tell them to grow and to keep them growing in a healthy way, can we target those very specifically? Can we build a drug that will stick to that and stop it working? And a lot of the interest has been clustered around the B cell and either killing B cells or squishing these cells or reducing the amount of activity they have. But it illustrates the names. And in bold, and I've already noticed one or two typos there, so apologies for that, but within bold there are a number of different medications. These are all things that have been or are in development. So you can see, in terms of frustration and hope, enormous hope that there are lots of things that are being looked at the moment. So if we're thinking about treating patients with lupus, we also need to think, here are just symptoms, and this is without looking inside the body at other areas. We need drugs that can work on skin and joints and kidneys and all the different, and fatigue and all the different features of disease that someone might experience. And different drugs might do different things in different situations at different times, but we're considering that when we're thinking about new drugs. And then we might think about how someone is treated over the time of their disease, and that they might need different treatments at different times. This is just a lupus journey slide, the idea of a diagnosis as early as you can, being sure what the prognosis is and trying to guess how bad the disease will be, starting with simpler things if the disease isn't too serious, maybe some anti-malarials, maybe a small amount of steroid, very small amount sometimes, increasing if necessary, then maybe immunosuppressive drugs like azathioprine and mycophenolate, and then maybe if it's very bad or if things accelerate and get worse for that small number of people, then stronger things like the biological therapies that I'm going to talk about more, and cyclophosphamide. And then other things that are going on. So I've put the mimics. It's always important in my mind. I'll just check, is there anything else that is caused? There's a tendency when you have a diagnosis of lupus for everything that ever happens to you to be put down to lupus. And of course people can still get flu and they can still get other problems. It's very important to consider that. Now this is a slide just to remind me to talk about when you decide to treat people. Now I mentioned it would be nice to treat early, and there's a very obvious reason for that, isn't there? If you treat someone before they're harmed by an illness, that just makes sense. But maybe if we treat early enough, you can change the diseases a bit. Now I'm not sure we can do that at the moment, but conceptually. And this just illustrates some nice work that says if you look at people's blood way before they're first diagnosed with lupus, and people have done this in certain circumstances, they start to have the blood test for lupus, things like the ANA, within the blood years before. So actually some of these things are changing a long time before, and wouldn't it be good if we could find those people very, very early? I'm not sure we can do that yet, but wouldn't that be interesting to do? And the other thing that's worth thinking about with newer treatments is who gets lupus? What people get lupus? And this looks at information that shows that men and women get lupus across all ages, but it's more common in women, perhaps 10 to 1, and it's more common that people start to develop disease through their 30s, 40s, and if you look at what age most people are with lupus, as we live longer and longer, there are more and more people in the older age group who have lupus because people are living longer and longer, and those are important considerations when we decide how to treat. Because at various different stages of life, there are different considerations. At some stage of life, we might worry about drugs having effects on fertility or an unborn child. At other stages of life, we may be worried about someone being more vulnerable to infection or more vulnerable to, because they have other illnesses and diseases, like heart disease, for example, as someone gets older, so different areas. And the other thing that we might change, and I mentioned my sort of journey around the world in terms of working in different places, is thinking about what lupus looked like in those different places. And it is very different in different geographical areas, in different ethnic groups. So in London I saw populations with very bad lupus in an Afro-Caribbean population particularly, a West African ancestry population. And then in Singapore, in an Asian Chinese population, very bad lupus. And then in Southampton, with a mainly Northern European population, disease that wasn't as severe in terms of kidney disease, but had more joint disease and more skin disease. So you see these differences between. And so when I'm seeing people and I'm choosing drugs and I'm trying to make decisions, I'm trying to work out as best I can what's the disease likely to turn out like, and there will be more or less in different parts of the world, and it will be more likely to be more severe. And certain parts of disease are more likely in certain situations. These are just a couple of illustrations from when I worked in Singapore. So a very rare complication of lupus is inflammation in the lungs causing bleeding into the lungs. Very, very rare. I almost never see that in Southampton, but it was a not uncommon feature in an Asian population in Singapore. Or inflammation in the gut, which I almost never see in the patients I see in Southampton, but I saw quite often in that population. So when I'm deciding on how severe it will be, how aggressive a drug might be, I'm thinking about ethnicity and race, I'm thinking about age, I'm thinking about gender. Are the kidneys involved? Is the brain involved? Is there sticky blood, antiphospholipid syndrome as well? And all of those things are influencing me and getting me to consider where in the pathway am I going to treat people. Is it earlier with prednisolone, hydroxychloroquine, or do I need the question marks to the right, these newer therapies? Now, one of the other reasons for wanting to develop new medications is also to reduce side effects. And this is showing a problem which, thankfully, I very rarely see nowadays, but which was associated with very high doses of steroids being used in the past. And that was getting damage to the bone within the hip joint, within the head of the femur, something called avascular necrosis. It means no blood getting to the head of the femur. And as a result, people sometimes needing a hip replacement. So anything we do tries to aim at reducing the amount of steroids. But as I said again, not to say steroids are not very useful and life-saving sometimes, but just trying to limit the dose. And when you do, and this is a little illustration of some work that I was involved in Singapore, we can use much lower dose of steroids than we thought we can and still get good efficacy and reduce side effects as well. And finally, when we think about treatment, we think about things called comorbidity. So what else does the patient have other than having lupus itself? Are they at risk of infections? Do I have to be careful about how aggressively I damp down this person's immune system? Will there be infectious problems? Do they have some heart disease as well? Do they have thin bones? Do I need to manage osteoporosis in that context? All of those things are important as well. And finally, when you think about medication, we also can't forget very simple things like general health measures. Smoking seems to be associated with worse lupus, with less response to treatment, with likelihood of developing the disease. And maybe as people smoke less in the society that we live in, maybe disease becomes a little bit milder for some people as well. So the smoking and general health measures are very, very important in that context, as are considering this difference in severity between lupus being something very, very mild and sometimes being very, very severe. So that's enough background. So a little bit more about new therapies and where they fit. And I hope you don't mind, I was going to have a little detour into the immune system and just to think about it, because to understand that slide I showed you of those two circles with B cells and T cells and this immune system that we all have and we all need, that will protect us all from the infections that we're exposed to every day. So here's looking at the blood. This is a slide of the blood. And if you take a drop of any of our blood and you look under the microscope, you will see different cells. And you will see a number of fairly oval, smaller, sort of pinky cells there, which are the red blood cells, carrying hemoglobin and oxygen as a result. And then you can see the bigger, chunkier cells, and those are white blood cells, some of which are neutrophils. Neutrophils are the white blood cells that form pus. If anyone's had a boil or a pimple, their white stuff is dead neutrophils. They're a bit thick, they charge in really quickly and try and get rid of an infection. They die really quickly. And then you have lymphocytes, other cells that are a bit more thoughtful about it. They try and target infections in a different way. And the lymphocytes, those cells, have become the white blood cells that are largely involved in the targeting of new therapies. So white blood cells in the immune system. Now, if you'll indulge me for a moment, I've put up some Welsh rugby players here because something very important is happening at 4 o'clock. As a closet Welshman, you can see Edwards as my ancestry at 4 o'clock, actually, and that isn't the reason I'm leaving early. I'm going to my brother's 25th wedding anniversary celebration in London this evening. But if I'd had a ticket, I probably would have gone to the rugby. And this was to illustrate some of what the immune system has to do and some of what we try to block in the context of the newer therapies that we're using. So imagine the top slide is showing a rolling maul. In that context, all the players are all crowded together and they're communicating by touch and feel. They interact with each other very directly, short-range signals. White blood cells can do that. You can block their ability to do that and change the immune system. Or you can send a little message. The next slide is throwing the rugby ball to the next person. That rugby ball is like a message of a chemical that we would call a cytokine. This is a short-range message that tells the next white blood cell to do something. So in this context, all of those things become targets that we might want to treat. Here's another illustration of a B cell. What does a B cell do? A white blood cell, called a lymphocyte, a B cell. It makes antibodies, and this hedgehoggy cartoon shows it covered in antibodies that it's throwing out into the system and might cause disease, and we might need to try and block as well. And then this further cartoon is another demonstration of what that antibody looks like. So when people say an antibody, it's a Y-shaped protein with hands on the ends of the arms, and those hands are uniquely shaped, usually to bind to viruses and bacteria, but in lupus to bind to bits of your own body as well. And cleverly now, with lots of the new therapies, we hijack that system, we build new antibodies in cells, we give them new sets of hands that will bind to the B cells or the T cells or some of the other chemicals that are important in the running of the immune system, and we can block those. So with that B cell, T cell, little messages being blocked, you start to make sense of these circles that are seen. And maybe you can see now that the T cell and the B cell are talking to each other through some of those little arms that stick out. We can block that. That the B cell to live needs growth factors to tell it to grow and divide. We can block that. And that both of those cells might produce chemicals, cytokines, that we can block as well with antibodies that are developed, grown in a laboratory and can be used as treatment. And some treatments like rituximab that you'll have heard about perhaps and belimumab are like this. Some of them really stand out as more famous things. And now you see all of these dark, highlighted, bolded up names. These are all the drugs in development as well. Now, because the studies have been difficult, and I think Professor Bruce is going to talk a little bit more about this, there are registries. There's a biologics registry, a registry run by Ian in Manchester, looking at how we use the drugs to try and generate UK-wide information on how best to use these drugs, to show to payers that these are effective and that they're safe as well, and we're able to use them, so that we're able to slot them in to these pathways that we're talking about. Now, there remain particular challenges. Some bits of lupus are still very difficult to treat. Sometimes skin disease can be very resistant in patients I see, and people have skin disease and hair loss as a result can be very resistant. Sometimes muscle disease is very resistant. When there's inflammation in muscle, sometimes brain disease can be very difficult as well. But I don't want it all to sound negative. There are lots of newer therapies. There have been difficulties with lots of the studies that have been done, but lots of things are coming out. And here's back to Becky. Remember I showed you that slide of Becky's scan, wasn't it? So that was her at 13. And then this is Becky, a number of years later. I think she's gone from being very, very sick to now being on a very small little bit of prednisolone, a very small amount of azathioprine. She's on blood-thinning drugs. She's on an anticoagulant called warfarin. And she's had rituximab at one stage as well, one of the newer therapies that gets rid of those B cells that I mentioned. But you can see, within many situations, there's difficulty, but often there's success as well, as there is for Becky. And so here's the slide of frustration and hope, and I'd like to think with all of those drugs being developed, with the stratification, this individualisation of medicine that I think Ian's going to talk about, there's lots of hope. And finally, just to leave you with, I can't do anything in terms of helping to treat patients or trying to help to treat patients. We've got lots of people in teams, and I'm very lucky in Southampton to be part of a team of specialist nurses. Sally, who's the dark blue wearing blonde nurse on one side, on the left-hand side, Sally, her first 6 years in post were paid for by Lupus UK. So that expertise wouldn't be there without the help of charities like Lupus UK. and then to finish off by thanking you to all of you for listening, and to all of the funders that have helped, and my colleagues in Southampton. Thank you very much.
Thank you very much indeed. Chris, can you hear me okay? Coming through okay? No? Coming through now. Maybe difficult to hear at the back. Now, has anyone got a question? And we'll send this mic down. No hands.
Sorry.
Yeah, of course.
Much research done in dietetics for, with nutrition and...
Yeah. Okay, so it's a good question, and if people didn't hear it, so it's a question about diet and dietetics and using that. So there are a few things that it makes me think. One is, when I was at St Thomas's, we had a very early computer touchscreen that was in a room for patients to ask questions about lupus. And it was very interesting that of the two most common things asked, diet and nutrition was one of the most common things people asked, which they didn't often always ask the doctors in the clinic. I think at some level there's very little information. I think doing dietetic work really well scientifically requires a great knowledge of nutrition, which actually is not something widely taught in medical schools and something we're not really expert at. We're at the moment doing a little bit of work in Southampton because there's a nutrition biomedical research centre within Southampton. But I haven't got really consistent evidence. There's some other work for inflammatory diseases. There are related diseases like rheumatoid, where there are little suggestions that red meat might not be quite as good as having fish and omega-3 fatty acids. But I have lots of patients who come and tell me if I have changed that in my diet. Some people, if they avoid gluten, they don't have celiac disease, seem to be better. Some people, if they avoid potatoes and tomatoes, seem to be better. But that's not scientifically based. That's people coming and saying that they're changing their diet and they feel better. And if they're eating a balanced diet, then I'm very happy for them to do that. But I think the hard facts of it are actually quite lacking.
There's a question here. Do you want to use the mic?
It's hereditary risk. My 9-year-old, can she be tested and have it shown her blood now, as you were talking about?
Yeah. Okay, so the question was about hereditary. And this is a common question. People are often worried, will I pass this on to my children? Is there a risk to my children? I mean, even if you look at twin studies, if someone has lupus and they had an identical twin sister, what would be the chance? The chance is less than 50%. And that says that it's even with pretty much identical genes, although they'll switch on and off slightly differently, even in identical twins, it's not inevitable that someone that closely related. And so for children, although the risk is slightly increased, it's not a very great increase. And then you get into discussion, well, wouldn't you just test? Now, my personal approach would be, and the thing that I advise people is, if the children are well, I wouldn't do any, I wouldn't test them, I wouldn't confuse it, because there's a tendency in families for people to perhaps have some of the screening antibodies, like an ANA, a bit more often, but it doesn't mean they have the disease. And if the children are well, I think it just creates more worry and concern, and they have a blood test that they don't need. So if it was my children, I would keep an eye on them. If they had symptoms that couldn't be sorted out by the GP and it was unexplained, then I'd want a lupus test, particularly when they started going through puberty and teenage years, particularly if they were girls. But I wouldn't just routinely test it. That would be my approach.
Anybody else like to ask a question?
I just asked,
I'm here.
Sorry, I have a history of malignant melanoma as well, and I'm just wondering what in the immune suppressant, do you know in terms of in case of triggering off?
Yeah. No, I think that's a really good and really practical question. So the question was about if someone's had a cancer, how does that influence your choice of drugs? And I think it inevitably does. Some people can have quite a black and white view about it. They'll say, there's been a cancer, therefore I will not use certain drugs. I will not use azathioprine because maybe that drug increases the likelihood of skin cancers. I won't use strong biological drugs. I think sometimes it's more complicated than that because I think it depends how bad the lupus is. So if someone had life-threatening lupus or organ-threatening lupus, you may discuss that with people and say, look, we have to take a risk here and we have to decide, and then it will be very much down to the individual to weigh up. Because risk means different things to all of us, doesn't it? Where we put risk in and what we're happy to do is very variable. In general, you would be cautious if someone had had a malignant melanoma, but I think it also depends exactly what it was done. So if someone had it years before, it was cut out and they thought it was all excised and therefore they think it's a cure, that would influence me in a certain way to be less worried about it. than if they weren't sure and it was much more recent. So I think these things end up being discussions and decisions between patients and doctors in the clinic.
There's a question down here.
I just want to ask a question about the effect on the skin.
Yeah.
In your experience of treating patients, what do you find has been most effective?
Yeah, okay, so it's a question about treating skin. I think it's really variable, to be honest, and I mentioned in things are still difficult. Sometimes I find it very difficult, with honesty, to completely treat some people's skin disease. Most. And it depends the sort. So people have a malar rash on their face, or they have subacute cutaneous lupus, or they have some of the less scarring types of disease. Sometimes that's very easily treated by just controlling the disease itself and the drugs that would normally work. And then I have some people who have more discoid type lupus or some very aggressive lupus skin rashes, which I've used all of the drugs on the list I've mentioned, including rituximab, including belimumab, one of the newer medicines, and it's still difficult. So it's an area that I sometimes struggle with. There are some things that we consistently use. We use a lot of anti-malarials, a lot of hydroxychloroquine. For some people that work well. We sometimes add in a medicine called mepicrine, along with the hydroxychloroquine. Then sometimes we use all of those other medicines I've said, depending on the situation. For most people, that controls it. Then there are also simple measures. Some people's lupus rashes, depends the sort they have, are made worse by smoking or being around people who smoke. And for some people, sunlight exposure is very important. Not for everybody, but some people a lot. And all of us think, particularly if we live in, maybe if we live in Belfast, if we live in Southampton, there's not that much sun in the summer, is there? But even so, for some people, that UV light, and the telltale for me is it's on their ears and it's in the little V where someone's top is perhaps not covering them. So some simple things can be helpful in that context. And then if I'm stuck as well, it's helpful using my colleagues in dermatology because just sometimes our diagnosis is wrong in that. And if it's going badly, I always ask them again, can you have another think? And do we need a little biopsy to be sure? But it's one of a challenging area, I think, for some people and needs new drugs.
I think we have time for one more question.
Sorry,
I think you had your hand up.
can lupus be diagnosed other than by a blood specimen?
We rely quite a lot on blood specimens to make the diagnosis. It's a mixture of things. It depends a bit on the sort of lupus someone has. So, for example, I can't imagine a situation where I wouldn't try and have a blood test. But if someone has very definite skin disease and you took a biopsy and it showed lupus, if someone had kidney disease and you had a biopsy from the kidney, that might be enough to make the diagnosis. There are also some people that people think might have what's called seronegative lupus. The test can be negative. In that situation, I believe conceptually that's possible. There are some people I see who their antibodies are negative at some of the time, and they might have kidney disease, for example, but it's very, very rare. So if someone's tests are completely negative, I'm really cautious and I'm really thoughtful that it isn't something else and I'm not making the right diagnosis. But it's a complicated disease, so many things are possible.
Chris, thank you very much indeed. We've all enjoyed it.